I'm Rashmi Halker Singh. I'm the Deputy Editor of Headache, and I'm joined today by two colleagues who wrote a recent publication entitled Advanced Clinical Reasoning in the Diagnosis of Spinal Cerebrospinal Fluid Leaks. Welcome, Dr. Matt Robbins and Dr. Gayle Salama. I'm so happy to talk to you both about this paper.
We're thrilled to join you, Dr. Halker Singh. Thank you.
Yes, thanks for the invitation. We're happy to be here.
Of course. So, this is a really interesting paper. It was very educational to read, but it's a little bit of an interesting format. So I was wondering if you could just tell me a little bit about, first of all, about what the paper is about, and then how you all came up with this idea.
Yeah, I'll start. I think, I'm just completely lucky that I work in a wonderful place that has led me to meet a fantastic neuroradiologist who has a similar clinical interest in Dr. Salama, and also Dr. Chasen, who is our colleague and co-author on this paper, who works at, who used to work with us and also now works at a hospital across the street and is on faculty at Cornell. And the original idea for this paper came about an invited presentation to have a neurologist who's a headache specialist speak about spinal CSF leaks to an audience of mostly neuroradiologists at a spine meeting that Dr. Salama is heavily involved with, and Dr. Chasen is now the president of the American Society for Spine Radiology. And in having that presentation, we realized there's just so much synergy between discussing these cases from different points of view, and there's so much nuance in these patients who really deserve better models of integrated care, that it led to us kind of taking sort of the foundation of what I discussed from the neurologist headache specialist point of view to this radiology audience, and trying to see how we could find common ground in what we grapple with on a day-to-day in seeing these patients. And these patients are very complicated. And we tried to frame it in these different scenarios where the clinical neurologist, the headache specialist, the neuroradiologist, other proceduralists may weigh in and have different points of view. And it really came from sort of these three clinical scenarios: when you think there's a leak, but you haven't really quite found one, or someone made an alternative diagnosis. When a leak has been diagnosed, maybe it's been treated, maybe it hasn't been, but then there's this change in symptoms, and what does it mean? And then someone who has a cerebrospinal fluid leak that was treated, but then symptoms happen again, or new symptoms happen, and how do you handle that? And there's so much nuance in the clinical assessment, in the neuroradiology of these patients, that it was great to kind of get our thoughts together in this viewpoint that we thought would be great for an audience of all clinicians who handle these patients, because the awareness has increased to the extent where we see this all the time in clinical practice. Spontaneously, our residents are presenting these cases in Morning Report all the time. I think Dr. Salama has very similar experiences.
Yes, just to piggyback, as Dr. Robbins said, there are scenarios where the clinical picture is leading you in one direction, but not all the pieces fit together, and it becomes very challenging. And our group, takes on all sorts of patients with complex medical histories, and lots of different pieces of data are at play. And I think it really takes an interdisciplinary approach with multiple subspecialists who really have a niche and a good background on spinal CSF leaks to look at all the pieces of data and truly use advanced clinical reasoning to decide the next best step for these patients. And it's not always clear. And working together and thinking through these scenarios provides the best patient care that we possibly can.
Yes, I mean, what you're saying, what you're both saying resonates with me so much. I'm a clinician. I take care of people who live with headache disorders every single day. And these scenarios that you outline in your paper are things that I encounter in my clinical practice. And I'm constantly looking to my colleagues in, interventional neuroradiology, neurosurgery, all these other disciplines to help with the management. And they're very, very common situations. And so this was a really useful paper that I know that I'll be referring to over and over again, and also having, our trainees take a look at as well. I think you're both master educators. I'm just going to put that out there. But I think that even when someone is an excellent educator, when we're putting together a paper, there's things that we ourselves can learn. So I'm curious, what did you each learn as you put together this project?
Well, I'll start. I think one item is that there is this very difficult um, framework for these patients about how sure are you about the diagnosis when there isn't an absolute biomarker that proves that someone does not have something in, does not have a certain diagnosis. So I think part of sort of grappling with this material and what we see in clinical practice and how we handle our own sort of interdisciplinary care approach is have you really ruled this out or really ruled this in? And I think we often are really surprised when we see a patient like I did today, who Dr. Salama already saw, who has like a rip roaring dural tear and CSF leak, and her brain MRI was stone cold normal. And I think you have to think about the opposite also. Are we a victim of our own success? We see lots of patients who come into us saying, I have a spinal CSF leak and I know it. And then I scratch my head and I see them and I take a history and I review their imaging if they've had it already. And I might talk to Dr. Salama or a colleague and say, you know what, I think you actually don't have a spinal CSF leak because my thinking is leading more towards another disorder that might feature headache that might be perceived as orthostatic, like cervicogenic headache, or a dysautonomia like POTS, or maybe it's just new daily persistent headache more generically, where headache started abruptly, and maybe it was after some infection, or maybe it was spontaneous. So I think there's a lot of humility to learn from these cases, and we wanted to try to kind of somewhat be devil's advocate, saying, did you really rule this in, or did you really rule this out? Because you really need a lot of depth of thought for the individual case to consider both the clinical factors and then also the radiological factors.
I agreed with everything that Dr. Robbins mentioned, and certainly learned, those points as well. I think for me, I learned something that I hope was inferred from the paper, but maybe we didn't say explicitly. And that's the importance of communicating certainty or lack thereof, both with patients and with the people that we're working with, whether it's an outside refer or even within our own group. And really understanding for ourselves as providers, and also having our referrers and team players understand as well that this diagnosis isn't always a certainty. And if we can express to one another the probability based on data, the probability based on clinical scenario, and our certainty and uncertainty with the diagnosis, I think that benefits the patient, both in terms of selecting the next best steps, selecting treatment options, as well as setting expectations for the patient and having them understand their own status and the status of our certainty or lack thereof.
Excellent. Those are really important points. Well, thank you so much for taking the time to speak with me, and thank you for your work. This is really excellent, and we appreciate everything you both do.
Thanks for having us. This was awesome.
Thank you.